A child suddenly starts vomiting. They become drowsy. Then come the seizures. They may even become confused or lose awareness of what is happening around them. A teenager begins behaving differently. Their grades start to fall. Their memory gets worse. An adult is diagnosed with depression or anxiety. They may even have an episode that looks like psychosis. But their response to medication is anything but typical. At first glance, this might look like gastroenteritis. It might look like epilepsy. It might look like a psychiatric disorder. Or it might seem like a routine developmental problem. But with inborn errors of metabolism, or IEMs, the real scene of the crime is often not the symptom we can see. It is inside the cells, inside a metabolic pathway that has become blocked. You can think of that pathway as an assembly line in a factory. Raw materials enter. Enzymes process them. Cofactors help the enzymes do their jobs, and the finished products move on to the next step. But if one enzyme stops working, a transporter malfunctions, cofactor metabolism is disrupted, an organelle is impaired, or gene regulation breaks down, the entire assembly line can stall. Upstream substrates begin to accumulate. Downstream products become insufficient, and toxic byproducts may build up through alternative pathways. Eventually, the damage may reach the brain or the liver. It may affect the heart, the muscles, the kidneys, or even the eyes. That is why treating an IEM is not simply about adding a few nutrients. And it is not about seeing a symptom and reaching for one supposed miracle cure. The real goal is to bring a disrupted metabolic pathway back toward a more stable state. Chapter 1. First, find the metabolic fingerprint. Where is the pathway blocked? The first step in treating an IEM is to determine exactly where the metabolic pathway has stalled. Doctors look for many different clues. Is the blood ammonia elevated? Is the blood glucose low? Are lactate or pyruvate levels abnormal? Has the body's acid-base balance become disrupted? Are specific plasma amino acids too high or too low? Does urine organic acid testing show abnormal metabolites? Does the acylcarnitine profile suggest a fatty acid oxidation disorder or an organic acidemia? Are homocysteine, methionine, or methylmalonic acid abnormal? Are 5-methyl tetrahydrofolate or 5-MTHF neurotransmitter metabolites, lactate, or glucose abnormal in the cerebrospinal fluid? Does brain magnetic resonance imaging, or MRI, or magnetic resonance spectroscopy, or MRS, show injury to the basal ganglia? Are there white matter abnormalities, cerebral atrophy, a lactate peak, or signs of metabolic brain injury? And there is another critical question. Do the genetic findings match the biochemical evidence and the clinical presentation? These findings are like fingerprints left behind at the scene. They do more than help establish the diagnosis. They can also point toward the right treatment. If the main problem is the buildup of a toxic substrate, treatment may focus on reducing that substrate or blocking its production upstream. If the problem is a missing product, treatment may focus on replacing that product or providing an alternative source of energy. If ammonia, copper, iron, oxalate, organic acids, or porphyrin precursors cannot be cleared properly, treatment may need to increase their removal or reduce their production. If an enzyme still has some residual activity, a cofactor may help it work a little more effectively. If the main metabolic defect is in the liver, a liver transplant may sometimes provide new metabolic capacity. And if the underlying cause is a single gene defect, gene therapy, RNA-based therapy, or gene editing may offer a future direction. That is why IEM treatment cannot focus on symptoms alone. and it cannot push every patient toward the same so-called repair therapy. Treatment has to return to the metabolic pathway itself. Which step has failed? Which substrate is accumulating? Which product is missing? Which toxic compound is injuring the brain? Which organs have already been affected? And which treatment can actually change the pathway? This is also what makes dietary treatment for IEMs fundamentally different from conventional nutrition. For a healthy person, protein, fat, sugars, and vitamins are simply nutrients. But for someone with an IEM, the very same nutrient may also be a substrate. It may become a source of toxic metabolites, or it may serve as a life-saving treatment. Chapter 2. Dietary Therapy. In IEMs, food itself is a prescription. Conventional nutrition tells us that protein, fat, carbohydrates, cholesterol, vitamins, and minerals are all important. But in an IEM, the role of a nutrient can change completely. For one child, protein is essential for growth. But in a urea cycle disorder, or UCD, and in certain organic acidemias, too much protein or a catabolic state may trigger hyperammonemia. In long-chain fatty acid oxidation disorders, fat may become a metabolic burden that has to be restricted. But in conditions such as glucose transporter, type 1 deficiency syndrome, or GLUT1 deficiency syndrome, fat and ketone bodies can serve as alternative fuels for the brain. Most people associate cholesterol with cardiovascular risk. But in Smith-Lemli-Opitz syndrome, or SLOS, cholesterol is a downstream product that the body cannot make in adequate amounts and may need to be replaced. That is why dietary treatment for an IEM is not simply about eating healthier. It is more like a metabolic prescription. Strategy 1. Reduce the substrate. Stop adding more pressure to a blocked pathway. For many small molecule IEMs, one of the first treatment strategies is to reduce the substrate the body cannot process. Consider phenylketonuria, or PKU. In PKU, phenylalanine cannot be efficiently converted into tyrosine. If phenylalanine remains elevated for a long time, it can interfere with brain development. It can lead to intellectual disability, seizures, behavioral problems, and even psychiatric symptoms. Treatment, therefore, includes a protein-restricted diet that limits phenylalanine. Another example is maple syrup urine disease, or MSUD. People with MSUD cannot properly break down the branched-chain amino acids leucine, isoleucine, and valine. Leucine, in particular, can be highly toxic to the brain. Treatment, therefore, includes a protein-restricted diet that carefully controls the branched-chain amino acids. Now, consider urea cycle disorders. Protein metabolism produces nitrogen. Normally, the urea cycle converts that nitrogen into urea, which can then be excreted in the urine. But in a person with a UCD, that pathway does not work properly. Ammonia can rise. And ammonia is extremely dangerous to the brain. Treatment may include a protein-restricted diet, adequate calories, arginine or citrulline, nitrogen-scavenging medications, and during a severe acute crisis, even dialysis. The goal is clear: reduce the toxic impact of ammonia on the brain. Other examples include methylmalonic acidemia, or MMA, and propionic acidemia, or PA. These organic acidemias often require restriction of certain amino acid precursors that can generate propionyl coenzyme A, or propionyl CoA. These include isoleucine, valine, methionine, and threonine. But in an IEM, a lower protein diet is not automatically better. There are two essential limits. First, Natural protein intake must be adjusted to each patient's individual protein tolerance. Protein should never be restricted so severely that it interferes with growth, tissue repair, or immune function. Second, when necessary, patients need disease-specific medical formulas. These formulas help provide an appropriate balance of amino acids, energy, vitamins, and minerals. Strategy 2. Carbohydrate-based dietary strategies. Some disorders require more glucose. Others require less. In classic galactosemia, dietary treatment requires restricting lactose and galactose from dairy products. In glycogen storage disease type 1, or GSD1, the central goal is to prevent fasting hypoglycemia. Treatment may include frequent feedings. Uncooked cornstarch, or an extended-release cornstarch product to help maintain blood glucose. It also includes limiting fructose, sucrose, and galactose, along with moderate restriction of fat. But the dietary strategies for GSD types 3, 6, and 9 are not exactly the same. Some require a higher protein diet. Some require cornstarch. Some require less carbohydrate. And some must be individualized according to complications and biochemical findings. Hereditary fructose intolerance requires avoiding fructose, sorbitol, sucrose, sucralose, polysorbates, and ingredients derived from them. This is why the phrase, "a disorder of sugar metabolism," does not simply mean eat less sugar. Different pathways require completely different answers. Strategy 3. The ketogenic diet. Giving the brain a different fuel, but it is not safe for every IEM. The classic IEM treated with a ketogenic diet is GLUT1 deficiency syndrome. In this disorder, glucose cannot cross the blood-brain barrier efficiently enough to reach the brain. There may be plenty of glucose in the body, but the brain cannot access enough of it. As a result, patients may develop seizures, developmental delay, movement disorders, episodes of abnormal movement, and cognitive or behavioral difficulties. The ketogenic diet causes the body to produce ketone bodies. These ketones give the brain an alternative source of fuel that does not depend on GLUT1 transport. The ketogenic diet is also commonly used in pyruvate dehydrogenase complex deficiency, or PDCD. In this condition, the metabolic block occurs before glucose-derived fuel can enter the tricarboxylic acid cycle, or TCA cycle. Ketone bodies can partially bypass that block and provide energy to the brain. But one point must be emphasized. The ketogenic diet is not appropriate simply because someone has epilepsy. And it is not safe for every IEM. Fatty acid oxidation disorders, defects of carnitine transport or utilization, pyruvate, carboxylase deficiency, and certain porphyrias may all carry serious risks when the body is forced to rely on fat or ketones. That is why the ketogenic diet must be used under the supervision of an experienced medical team. Strategy 4. Recognizing the dietary pattern of citrin deficiency. Many people with citrin deficiency develop distinctive food preferences after the age of 1. They may dislike sweets. They may avoid rice, noodles, and other high-carbohydrate foods. Instead, they may prefer foods that are higher in protein and fat. Parents may assume the child is simply a picky eater. But in citrin deficiency, these preferences may represent the body's attempt to adapt to an underlying metabolic disorder. For these patients, a high carbohydrate load may make the metabolic problem worse. The usual dietary approach for citrin deficiency is relatively low in carbohydrates and higher in protein and fat. Some infants with neonatal intrahepatic cholestasis caused by citrin deficiency or NICCD, may also need a formula containing medium-chain triglycerides, or MCTs, along with fat-soluble vitamins. Strategy 5. Restricting specific sterols. Cytosterolemia is not treated with an ordinary low-fat diet. Cytosterolemia is associated with disease-causing variants in the ABCG5 or ABCG8 gene. The problem is not simply high cholesterol. The body absorbs too many plant sterols and shellfish-derived sterols. At the same time, it cannot eliminate them effectively. Treatment is therefore not just a standard low-fat diet. It requires limiting sources of non-cholesterol sterols. Treatment also commonly includes ezetimibe, which reduces the intestinal absorption of sterols. Strategy 6. Smith-Lemli-Opitz syndrome, replacing a missing downstream product. Smith-Lemli-Opitz syndrome is a disorder of cholesterol synthesis caused by variants in the DHCR7 gene. Patients cannot properly convert 7-dehydrocholesterol, or 7-DHC, into cholesterol. As a result, 7-DHC, 8-dehydrocholesterol, or 8-DHC, and other precursors accumulate. Cholesterol is usually low, but it is important to understand that some patients may have serum cholesterol levels within the normal range. The diagnosis, therefore, cannot be based on total cholesterol alone. SLOS can cause congenital anomalies, developmental delay, and intellectual disability. It is also frequently associated with autism-like behaviors. In SLOS, cholesterol is not simply a bad substance. It is a critical downstream product that the body cannot make in sufficient amounts and may need to be replaced. The goal of cholesterol supplementation is to replace that missing product. It may improve certain aspects of growth, photosensitivity, muscle tone, nerve conduction, development, cognition, and behavior. Strategy 7. Preventing catabolism. Many metabolic crises are triggered by fasting in some IEMs. Going without food may be more dangerous than eating the wrong food. When a healthy person goes without food for a short time, the body can break down glycogen, fat, and muscle to produce energy. But in certain IEMs, fasting, infection, fever, vomiting, diarrhea, surgery, or a prolonged inability to eat can push the body into a catabolic state. In other words, the body begins breaking down its own glycogen, fat, and muscle to produce fuel. For some people with an IEM, that is enough to trigger a metabolic crisis. After fasting, patients with fatty acid oxidation disorders may be unable to use fat efficiently for energy. They may develop hypoketotic hypoglycemia, liver dysfunction, rhabdomyolysis, cardiomyopathy, or even sudden death. In someone with a UCD, infection or fasting can cause muscle breakdown and release additional nitrogen. Blood ammonia may rise rapidly. During physiologic stress, people with organic acidemias are especially vulnerable to metabolic decompensation. They may develop acidosis, ketosis, hypoglycemia, and hyperammonemia. That is why many families affected by an IEM need an emergency treatment letter. They also need a sick day plan. If a child develops a fever, persistent vomiting, an inability to eat, severe drowsiness, or altered mental status, the family should not simply wait it out at home. The immediate priorities are to provide glucose and fluids promptly, to stop catabolism, and to monitor blood ammonia, blood glucose, blood gases, electrolytes, lactate, ketones, and other relevant metabolic markers. The key message from this chapter: Dietary treatment for an IEM may look like ordinary eating, but in reality, it is a way of regulating a metabolic pathway. Sometimes the goal is to reduce a substrate. Sometimes it is to replace a missing product. Sometimes the brain needs a different source of fuel. Sometimes treatment must prevent the body from entering catabolism. Sometimes a specific class of feed sugar or sterol must be avoided. And sometimes patients need additional cholesterol or amino acids that healthy people would not normally need to supplement. The real challenge is not simply to eat healthy. It is to eat in a way that fits the specific metabolic pathway that is not working properly. That is why dietary therapy for an IEM often has to be coordinated with medications, cofactors, and scavenger therapies. The plan must be adjusted over time according to body weight, age, calorie requirements, laboratory results, vitamin and trace element status, and the patient's growth curve. And it must be started under the supervision of an experienced team. That team may include a neurologist, a metabolic genetics specialist, and a metabolic dietitian. Chapter 3. Substrate Reduction Therapy. Turning down the faucet. Upstream substrate reduction therapy, or SRT, works through a simple idea. Treatment does not have to focus only on the place where the pathway is already blocked. Medication can also reduce the amount of substrate the body produces upstream. Think of a metabolic pathway as a drain pipe. If the pipe is already blocked downstream, one option is to clear the blockage, but another option is to turn down the faucet upstream. That reduces the pressure farther down the line. A classic example is hereditary tyrosinemia type 1, or HT1. The problem in HT1 is not simply elevated tyrosine. The greater danger comes from toxic metabolites, including succinylacetone, that form farther downstream in the tyrosine breakdown pathway. These toxic compounds can damage the liver and the kidneys. Nitisinone works by blocking the pathway at an earlier step. It inhibits an enzyme called 4-hydroxyphenylpyruvate dioxygenase, or HPPD. This reduces the formation of toxic metabolites downstream. But one point is essential. Nitisinone cannot be used alone to treat HT1. It must be combined with a diet that restricts both tyrosine and phenylalanine. Otherwise, upstream compounds may continue to rise. SRT follows a similar strategy in certain lysosomal storage disorders. You can think of the lysosome as the cell's recycling center. If a specific hydrolytic enzyme is deficient, certain lipids or carbohydrates cannot be broken down properly. Instead, they accumulate inside the cell. SRT reduces the production of those substrates. That helps relieve the pressure inside the cell's storage system. SRT has several potential advantages. Some of these medications can be taken by mouth, and some small molecules may be able to reach a wider range of tissues. But the limitations are equally clear. SRT usually does not repair the underlying gene. Instead, it reduces the burden created by the substrate. It is useful for only a limited number of disorders, and its long-term effectiveness, especially in the nervous system, depends on the specific disease. So SRT is not a universal treatment. It is more like applying the brakes upstream in the metabolic pathway. Chapter 4. Replacing missing products if something is missing. Downstream, replace it. In some IEMs, the problem is not only that toxic substances are accumulating, the body may also be missing something it is supposed to have. In that situation, treatment is not only about reducing what is excessive, it is also about replacing what is missing. Consider phenylketonuria, or PKU. After dietary phenylalanine has been restricted, patients still need a specialized amino acid formula. Why? because people with PKU cannot efficiently convert phenylalanine into tyrosine. As a result, tyrosine becomes a conditionally essential amino acid. In other words, if the body cannot make enough tyrosine through its own metabolic pathway, it has to be supplied through the therapeutic formula. Another example is a urea cycle disorder, or UCD. Some patients need arginine or citrulline. The goal is to support the parts of the urea cycle that can still function. This may help create a pathway for nitrogen to be carried away. But the approach differs among the various types of UCDs. In arginase deficiency, for example, arginine should not be supplemented indiscriminately. Now consider long-chain fatty acid oxidation disorders, or LCFAODs. Patients with these disorders often need to restrict long-chain triglycerides, or LCTs. At the same time, they may receive medium-chain triglycerides, or MCTs, or triheptanoin. Why? When the body cannot properly use long-chain fatty acids, medium-chain fatty acids can bypass parts of the blocked pathway and provide an alternative source of energy. Triheptanoin has an additional feature. It is an odd-chain, medium-chain triglyceride. It can generate propionyl CoA, which can then be converted into succinyl CoA. This helps replenish intermediates in the tricarboxylic acid cycle, or TCA cycle, and supports energy metabolism. Glycogen storage disease type 1, or GSD1, uses a similar principle. Patients cannot maintain a steady release of glucose. That makes them vulnerable to hypoglycemia during fasting. Uncooked cornstarch releases glucose slowly. This can help keep blood glucose more stable over time. Another example is molybdenum cofactor deficiency type A. Treatment is not simply a matter of taking vitamins. Instead, it replaces a missing intermediate in the metabolic pathway. Phosphodinopterin, for example, replaces cyclic pyranopterin monophosphate, or CPMP. When treatment begins early, it may have the potential to change the natural course of the disease. So, when we talk about replacing something in an IEM, it does not mean taking whatever supplement seems helpful. What should be replaced? How much is needed? And when should it be given? Every one of these decisions must be based on the specific disease and the patient's biochemical markers. The medical foods, amino acids, vitamins, minerals, and specialized fats used by many people with IEMs are not ordinary dietary supplements. They are part of the treatment itself. Chapter 5: Cofactor Therapy. Giving residual enzyme activity the tool it needs. Some enzymes are not completely inactive. They simply work with very low efficiency. In some cases, providing the cofactor that the enzyme requires may improve its residual activity. A cofactor is not a nutrient that becomes better when more and more is taken. It works more like a key. Consider thiamine, also known as vitamin B1. Thiamine is an important cofactor for the pyruvate dehydrogenase complex and the branched-chain alpha-ketoacid dehydrogenase complex. That is why some people with maple syrup urine disease, or MSUD, may respond to high-dose thiamine. The same may be true for some patients with pyruvate dehydrogenase complex deficiency, or PDCD. Another example is riboflavin, or vitamin B2. Riboflavin is a precursor of flavin mononucleotide, or FMN, and flavin adenine dinucleotide, or FAD. It is involved in respiratory chain complexes 1 and 2, fatty acid beta oxidation, and many other flavoprotein reactions. As a result, some patients with multiple acyl-CoA dehydrogenase deficiency, or MADD, may respond to riboflavin treatment. The same may be true for certain ACAD9-related mitochondrial disorders and riboflavin transporter deficiencies. Biotin is another example. It acts as a cofactor for several carboxylase enzymes. In biotinidase deficiency, timely treatment can prevent or improve many skin symptoms, seizures, and metabolic abnormalities. Then there is tetrahydrobiopterin, or BH4. BH4 is an essential cofactor for the hydroxylation of phenylalanine, tyrosine, and tryptophan. A deficiency of BH4 does more than disrupt phenylalanine metabolism. It can also interfere with the production of neurotransmitters such as dopamine and serotonin. Some patients with PKU may also respond to sapropterin. But one point must be emphasized. Cofactor therapy has to be guided by the specific disorder, by the genotype, by the amount of residual enzyme activity, and by the biochemical findings. A person should not begin high-dose B vitamins, folate, or hydroxycobalamin simply because they have seizures, autism, depression, or psychiatric symptoms. That approach may not work, and it may obscure the real underlying cause. Chapter 6, Vitamin B12, Folate, and 1-carbon metabolism, the methylation factory behind some psychiatric symptoms. When people hear about depression, anxiety, hallucinations, delusions, unusual behavior, or worsening memory, their first thought is often a psychiatric disorder. That is understandable. But in a small subset of patients, the real problem behind those psychiatric symptoms lies within a metabolic pathway, especially the folate cycle, the vitamin B12 cycle, homocysteine metabolism, and the methylation pathway. You can think of this system as a methylation factory inside the brain. Folate provides 1-carbon units. Vitamin B12 helps transfer methyl groups. Homocysteine is remethylated into methionine. Methionine then helps generate S-adenosylmethionine, or SAM. SAM is involved in DNA methylation, neurotransmitter metabolism, myelin maintenance, and brain development. That is why some people with IEMs do not initially present with a classic metabolic crisis. Instead, they may develop cognitive decline, changes in mood, psychosis-like symptoms, seizures, movement disorders, or even developmental regression. But this does not mean that folate treats psychiatric illness. A more accurate statement is this: folate-related treatment is appropriate only for a small number of clearly defined IEMs. These disorders specifically affect folate transport, 1-carbon metabolism, or vitamin B12-dependent remethylation pathways. Examples include FOLR, 1-related cerebral folate transport deficiency, certain cobalamin C disorders, and severe methylene tetrahydrofolate reductase deficiency. These conditions may cause behavioral or psychiatric symptoms. Treatment may involve specific forms of folate, vitamin B12, betaine, or a combination of therapies. But the treatment must be supported by objective evidence. That evidence may include homocysteine, methionine, methylmalonic acid, cerebrospinal fluid levels of 5-methyl tetrahydrofolate, or 5-MTHF, and the patient's genetic findings. Folate is not an empiric treatment for ordinary psychiatric symptoms. FOLR1, related cerebral folate transport deficiency. First, consider FOLR1, related cerebral folate transport deficiency, or FOLR1-CFTD. The key problem is this: folate levels in the blood may be normal, but the brain cannot access enough folate. FOLR1-CFTD is caused by impaired function of folate receptor alpha. This results in folate deficiency inside the central nervous system. A patient's peripheral blood folate may be normal, but the level of 5-MTHF in the cerebrospinal fluid may be extremely low. Without treatment, patients may develop developmental delay, progressive cognitive impairment, behavioral problems, seizures, and movement disorders. The main treatment is folinic acid, also known as leucovorin. This may be given as calcium folinate, or in its active levo form, levoleucovorin. Regular folic acid is not used to treat FOLR1C FTD. Folic acid can bind tightly to the FOLR1 receptor. This may interfere with any residual receptor function, so this condition is not simply a matter of being low in folate. The real problem is that folate cannot reach the brain effectively. Management requires assessment by a metabolic genetics specialist. It may also require monitoring of cerebrospinal fluid, 5-MTHF, and long-term follow-up. CBS deficiency. Next, consider cystathionine beta synthase deficiency, or CBS deficiency. This is also known as classic homocystinuria. The metabolic defect lies in the transsulfuration pathway. Normally, the CBS enzyme allows homocysteine to enter this pathway, but when CBS activity is deficient, homocysteine rises. Methionine is also often elevated. Patients may develop dislocation of the lens, skeletal abnormalities, an increased risk of blood clots, developmental delay, seizures, and behavioral or psychiatric symptoms. In this condition, folate primarily supports the remethylation pathway. It helps recycle homocysteine back into methionine. But the true treatment goal is to reduce total homocysteine. This helps lower the risk of blood clots and neurologic injury. Betaine can use the betaine homocysteine methyltransferase pathway, or BHMT pathway. This provides an alternative route for lowering homocysteine. But betaine can also cause methionine to rise. If methionine becomes extremely high, there is a risk of cerebral edema. That is why careful monitoring is essential. Betaine should not be used without medical supervision. Treatment must also determine whether the patient is responsive to vitamin B6. When necessary, treatment may include a methionine-restricted diet, along with folate, vitamin B12, betaine, and other disease-specific measures. Cobalamin C deficiency. The third example is methylmalonic acidemia with homocystinuria, cobalamin C type, or CBLC. This is an important disorder of intracellular vitamin B12 metabolism. It disrupts two metabolic pathways at the same time. One pathway causes methylmalonic acid to rise. The other causes homocysteine to rise, while methionine becomes low or remains in the low normal range. In infancy, CBLC may cause feeding difficulties, developmental delay, seizures, and retinal disease. But the disorder may also appear during adolescence or adulthood. Late-onset symptoms may include personality changes, social withdrawal, hallucinations, delusions, delirium, and cognitive decline. The presentation may even resemble dementia. Late-onset CBLC is especially likely to be mistaken for a primary psychiatric disorder. The central treatment is injectable hydroxycobalamin. When an intracellular cobalamin disorder is suspected, parenteral hydroxycobalamin usually needs to be started as early as possible. If total homocysteine is elevated, betaine is often added. Depending on the clinical situation, folic acid or folinic acid may also be used. But if the vitamin B12 pathway has not been adequately treated, folate alone may mask or obscure the underlying problem. A commonly discussed four-part regimen includes hydroxycobalamin, L-carnitine, folinic acid, and betaine. Each component targets a different part of the pathway. Hydroxycobalamin addresses the intracellular B12 processing defect. Betaine gives homocysteine an alternative remethylation pathway. Folinic acid supports the folate pool, and L-carnitine helps manage the acyl burden associated with organic acidemia. MTHFR deficiency. The fourth example is methylene tetrahydrofolate reductase deficiency, or MTHFR deficiency. The MTHFR enzyme converts upstream forms of folate into 5-MTHF. Severe MTHFR deficiency causes inadequate production of 5-MTHF. Homocysteine rises, and methionine may become low or remain in the low normal range. This can interfere with brain development, myelination, and methylation. Patients may develop seizures, developmental delay, encephalopathy, movement disorders, cognitive decline, mood disorders, or psychosis-like symptoms. In severe MTHFR deficiency, early treatment with betaine is important for improving survival and neurologic outcomes. Folic acid, folinic acid, or 5-MTHF may be used as adjunctive treatment, but the specific form must be selected by a specialist using the patient's biochemical findings. At this point, two very different situations must be separated. Severe MTHFR deficiency is not the same as the common MTHFR C677T or A1298C variants. Common MTHFR variants are not a reason to avoid folic acid. People with these common variants can still process different forms of folate, including folic acid. So an MTHFR polymorphism on a genetic report should not automatically be blamed for depression, anxiety, or psychiatric symptoms. And it is not a reason to combine high doses of 5-MTHF folinic acid and folic acid without medical supervision. Chapter 7: Scavenger Therapy, giving toxic metabolites another way out. Many IEMs cause disease because toxic metabolites accumulate inside the body. The goal of scavenger therapy is to create another pathway for removing those substances. First, consider nitrogen scavenging medications. People with urea cycle disorders cannot process ammonia normally. Ammonia can injure the brain. But nitrogen scavengers do not simply remove ammonia in its original form. Instead, they use alternative pathways to carry nitrogen out of the body. This reduces the overall ammonia burden. Sodium benzoate, for example, combines with glycine. This produces hypurate, which is excreted in the urine. Sodium phenylbutyrate and glycerol, phenylbutyrate, are ultimately converted into phenylacetate. Phenylacetate then combines with glutamine. This produces phenylacetylglutamine, which can be excreted from the body. Now consider metal-chelating medications. Wilson disease is a classic disorder of copper metabolism. When copper cannot be excreted properly, it may accumulate in the liver, the brain, and the cornea. Patients may develop liver disease, movement disorders, psychiatric symptoms, and Kaiser-Fleischer rings. Chelating medications can be used to increase copper excretion. Zinc salts may also be used to reduce the intestinal absorption of copper. Hereditary hemochromatosis involves a different problem. In this disorder, the body accumulates too much iron. Some patients may develop fatigue, liver disease, diabetes, cardiomyopathy, joint problems, and changes in mood or cognition. The treatment goal is to reduce the body's iron burden. For some patients who cannot undergo phlebotomy or controlled removal of blood, iron chelating medications may be considered. Scavenger and chelation therapies can be extremely powerful, but they are not detox wellness treatments. Chelating medications, nitrogen scavengers, and iron reduction therapies all require a confirmed diagnosis. They require careful dose management, and they require ongoing laboratory monitoring. Chapter 8. Enzyme Replacement Therapy. Delivering the missing enzyme. If a disease is caused by the loss of a specific enzyme, the most direct idea is to replace that enzyme. This is called enzyme replacement therapy, or ERT. ERT has become an important treatment for several lysosomal storage disorders. These include Gaucher disease, Fabry disease, Pompe disease, and certain mucopolysaccharidoses. Traditional ERT usually involves the intravenous infusion of a recombinant enzyme. Cells take up the enzyme and transport it into the lysosome. Once there, the enzyme helps break down the accumulated substrate. In phenylketonuria, or PKU, pegvaliase reflects a related enzyme substitution strategy. It does not replace the body's own phenylalanine hydroxylase enzyme, or PAH. Instead, it uses a PE-egylated form of phenylalanine ammonia lyase. This enzyme breaks down phenylalanine and lowers phenylalanine levels in the blood. But traditional intravenous ERT has one major limitation. Many replacement enzymes cannot effectively enter the central nervous system. Serliponase alpha, used for neuronal ceroid lipofuscinosis type 2 or CLN2 disease, is an important exception. It is delivered by intraventricular infusion. This allows the enzyme to enter the central nervous system through the cerebrospinal fluid. This points to an important direction for the future of ERT. It is not enough to replace the missing enzyme. The enzyme must also reach the right place. Inborn errors of metabolism, or IEMs, do not affect only the brain and the liver. Consider hypophosphatasia, or HPP. This disorder primarily affects bone mineralization. Asfotase alpha, marketed as Strensiq, is an example of RT designed to target the bone mineralization pathway. Another example is lysosomal acid lipase deficiency, or LALD. Sebelipase alpha, marketed as Canama, is used to treat LALD. It hydrolyzes cholesterol esters and triglycerides inside the lysosome. But ERT also has clear limitations. Many replacement enzymes cannot cross the blood-brain barrier. Proteins introduced from outside the body may trigger immune reactions, and ERT may not reverse irreversible brain injury, skeletal deformities, or organ fibrosis that has already developed. That is why ERT has the greatest potential when it begins early and reaches the correct tissues. Chapter 9. Pharmacological chaperone therapy. Helping a misfolded enzyme reach its destination. Some genetic variants do not cause an enzyme to disappear completely. Instead, they cause the enzyme to fold incorrectly. A misfolded enzyme is like a package with the wrong address. Before it ever reaches the place where it needs to work, the cell's quality control system may stop it and break it down. A pharmacological chaperone is a type of small molecule medication. It stabilizes certain misfolded enzymes. This can help the enzyme reach the lysosome or another target location. Once the enzyme arrives at its destination, the chaperone can separate from it. The enzyme's residual activity then has a chance to do its job. This type of treatment has several potential advantages. It can be taken by mouth. The molecules are small, and some may penetrate certain tissues more effectively. Migalastat in Fabry disease is a classic example. Fabry disease is a lysosomal storage disorder caused by deficient activity of alpha-galactosidase A. Traditional treatment may include ERT, but some patients with an amenable GLA variant may be treated with the oral pharmacological chaperone migalastat. Migalastat, marketed as Galafold, is used in adults with a confirmed diagnosis of Fabry disease and an amenable GLA variant. But if a genetic variant prevents the enzyme from being produced at all, there is no enzyme for the chaperone to rescue. This brings us back to a critical principle. IEM treatment cannot be based on the name of the disease alone. Doctors also have to consider the specific genetic variant, how that variant affects protein function, and whether enough residual function remains for treatment to rescue. Chapter 10. The mitochondrial cocktail, supporting the cell's energy factories but not treating it as a universal cure. Primary mitochondrial diseases, or PMDs, are a highly complex group of inherited disorders. Some are caused by variants in nuclear DNA. Others are caused by variants in mitochondrial DNA. But they share a central problem. Cellular energy production declines, and oxidative stress may increase. That is why organs with high energy demands are often the most vulnerable. The brain, the heart, the muscles, the liver, and the eyes. This also helps explain why some people with mitochondrial disease develop seizures, developmental delay, exercise intolerance, muscle weakness, vision or hearing problems, and even neuropsychiatric symptoms. So, what exactly is a mitochondrial cocktail? It is not one standardized prescription, and it is not a supplement combination that everyone should copy. It is better understood as individualized supportive therapy. Commonly considered components may include coenzyme Q10 or CoQ10, riboflavin or vitamin B2, thiamine or vitamin B1, L-carnitine, creatine, alpha-lipoic acid, vitamin C, vitamin E, N-acetylcysteine or NAC, arginine, citrulline, taurine, folinic acid, or 5-methyl tetrahydrofolate, also known as 5-MTHF. But whether these substances should be used at all, which ones should be selected, and how much should be given depend on several factors. The genetic diagnosis, the clinical presentation, the metabolic findings, and which organs have been affected. CoQ10, for example, is an important component of the electron transport chain. In primary CoQ10 deficiency, supplemental CoQ10 may have clear therapeutic value. Riboflavin is involved in respiratory chain complexes 1 and 2. It also supports fatty acid beta oxidation and many flavoprotein reactions. That is why some people with multiple acyl-CoA dehydrogenase deficiency, or MADD, may respond to riboflavin. The same may be true for certain mitochondrial respiratory chain defects. L-carnitine helps transport long-chain fatty acids into the mitochondria. It can also help remove certain potentially toxic acyl compounds. Creatine acts like a short-term energy buffer inside the cell. It may help some patients with muscle fatigue or exercise intolerance. NAC supports the glutathione antioxidant system. It has been studied in conditions involving oxidative stress, liver disease, retinal disease, and certain neurobehavioral settings. In mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes, or MELAS, arginine or citrulline may be used to support nitric oxide-mediated vasodilation and address the risk of stroke-like episodes. In pyruvate dehydrogenase complex deficiency, a ketogenic diet can partially bypass the defect in glucose oxidation. It provides the brain with ketone bodies as an alternative fuel. Some patients may also be considered for a trial of thiamine. But here is the essential point. A mitochondrial cocktail is not a cure, and it is not a universal treatment for every person with fatigue, developmental delay, autism, seizures, or psychiatric symptoms. It is often an empiric, individualized, and supportive approach. Treatment may need to be adjusted using lactate and pyruvate levels, the acyl-carnitine profile, creatine kinase, liver and kidney function, cardiac testing, eye examinations, and the patient's genetic findings. So, with a mitochondrial cocktail, more is not necessarily better. The real question is this: which energy pathway is impaired in this particular patient? Chapter Bar 11. Transplantation. Sometimes the metabolic factory, or a failing organ, has to be replaced. Many metabolic reactions take place in the liver. If the liver is the main site of the metabolic defect, or if that defect repeatedly causes life-threatening metabolic crises, a liver transplant may change the course of the disease. Consider certain urea cycle disorders. After liver transplantation, the donor liver can provide the missing urea cycle enzyme activity. This can greatly reduce the risk of recurrent hyperammonemic crises. Another example is hereditary tyrosinemia type 1, or HT1. Liver transplantation may become a treatment option if the patient develops severe liver failure, if the response to nitisinone is inadequate, or if there is concern about hepatocellular carcinoma. In some organic acidemias, liver transplantation may reduce the frequency of metabolic decompensation, but it may not resolve every neurologic or kidney-related problem. And liver transplantation is not the only type of transplant used in IEMs. Consider primary hyperoxaluria type 1, or PH1. The underlying problem is a deficiency of alanine glyoxylate aminotransferase, or AGT, in the liver. But the kidneys often bear the greatest damage. In PH1, liver transplantation can function as a targeted treatment. That is because it restores AGT activity in the liver. A kidney transplant can replace kidney function, but it cannot correct the underlying overproduction of oxalate. Now consider cystinosis. When advanced kidney failure develops, kidney transplantation may become necessary. But a kidney transplant does not cure cystine accumulation throughout the body. Patients still need systemic treatment. They also need eye-specific treatment. Methylmalonic acidemia can also cause chronic kidney disease. In severe cases, patients may require dialysis or kidney transplantation. Some may also be considered for liver transplantation or combined liver-kidney transplantation. Certain lysosomal storage disorders and peroxisomal disorders may be treated with hematopoietic stem cell transplantation, or HSCT. In some settings, this may involve bone marrow transplantation. The idea is to introduce donor-derived cells into the body. These cells can produce the missing enzyme over the long term. Through a process called cross-correction, the enzyme may then help nearby cells. This approach may be used in selected mucopolysaccharidoses, or MPS disorders, metachromatic leukodystrophy, or MLD, Krabbe disease, and X-linked adrenoleukodystrophy, or XALD. The earlier transplantation occurs, especially before clear neurodegenerative changes appear, the greater the chance of preserving function. But once brain injury has advanced too far, transplantation cannot restore dead or severely degenerated nervous tissue to its original state. Chapter 12. Gene-based therapies. Moving beyond metabolic management. Toward correcting the cause, most inborn errors of metabolism, or IEMs, are single-gene disorders. That makes gene-based therapy an important direction for both the present and the future. Several major approaches are being developed. One is gene addition. This means delivering a functional copy of a gene into the patient's cells. Another is ex vivo hematopoietic stem cell gene therapy. The patient's own blood-forming stem cells are collected first. A therapeutic gene is introduced into those cells outside the body. The modified cells are then infused back into the patient. Another approach is in vivo gene therapy using an adeno-associated virus, or AAV, as a delivery vector. The therapeutic gene may be delivered to the liver, the muscles, or selected tissues within the central nervous system. There are also RNA-based therapies. These include antisense oligonucleotides. RNA interference, or RNAi, and messenger RNA, or mRNA therapy. These approaches can change how much of a particular protein the body produces. Then there is gene editing. The goal may be to correct, insert, or regulate a disease-causing gene. These treatments are no longer just ideas for the future. Some have already become approved therapies that target the underlying cause or modify the course of disease. One example is Lenmeldi. Lenmeldi is used for selected children with metachromatic leukodystrophy, or MLD. It is an autologous hematopoietic stem cell-based gene therapy. It is indicated for children with presymptomatic late infantile MLD, presymptomatic early juvenile MLD, or early symptomatic early juvenile MLD. Skysona is another autologous hematopoietic stem cell-based gene therapy. It is used in selected boys between 4 and 17 years of age with early active cerebral adrenoleukodystrophy, or CALD. Its goal is to slow the progression of neurologic dysfunction. Aromatic L-amino acid decarboxylase deficiency, or AADC deficiency, also has an AAV vector-based gene therapy. It is called Kebilidi. Kebilidi uses targeted delivery into the putamen of the brain. It delivers a functional copy of the DDC gene. This helps restore AADC activity in pathways involved in dopamine and serotonin synthesis. But gene therapy is not a miracle. It is changing the treatment landscape for certain IEMs. But it cannot yet treat every IEM, and it cannot reverse every brain injury that has already occurred. Delivery efficiency, immune responses, long-term gene expression, safety, what happens as a child grows, reaching the correct tissue, and the cost of treatment. All of these remain real-world challenges. Chapter 13. Disease-specific therapies. Some IEMs require a special key. In real clinical practice, some treatments are highly specialized. They are not ordinary nutritional supplements, and they are not general metabolic support. They are designed for one specific pathway, one toxic metabolite, one transport defect, or one particular genetic disorder. It is like a detective finally finding the decisive piece of evidence, and then receiving the one key that fits that particular lock. Example 1. Cerebrotendinous xanthomatosis. Cerebrotendinous xanthomatosis, or CTX, is easily missed. Patients may first develop cataracts or chronic diarrhea. They may have learning difficulties, ataxia, seizures, or neuropsychiatric symptoms. Some develop pyramidal signs or peripheral neuropathy. Later, xanthomas may appear in the Achilles tendons. Early in the disease, many patients are thought to have an eye disorder, a neurologic disorder, a psychiatric illness, or a routine developmental problem. CTX is caused by pathogenic variants in the CYP27A1 gene. These variants disrupt the bile acid synthesis pathway. Normally, cholesterol is converted into bile acids, but in CTX, that pathway is blocked. Cholesterol metabolism is redirected down the wrong route. Cholestanol and other abnormal metabolites begin to rise. They can accumulate in the brain, the tendons, the lenses of the eyes, and other tissues. The key treatment is chenodeoxycholic acid, or CDCA. In the United States, it is also called chenodiol. CDCA does more than simply lower cholesterol. It replaces a missing bile acid signal. Through feedback inhibition, it tells the liver to reduce production of abnormal cholesterol-derived metabolites. Long-term CDCA treatment can normalize cholestanol levels in plasma and cerebrospinal fluid. It may also improve certain neurophysiologic findings. The earlier treatment begins, the greater the opportunity to prevent irreversible neurologic injury. Example 2. Bile acid synthesis disorders. Colic acid is not simply a digestive medication. It functions more like a feedback therapy. Patients with bile acid synthesis disorders may develop neonatal cholestasis, poor absorption of fat-soluble vitamins, liver disease, abnormal blood clotting, poor growth, and, in severe cases, cirrhosis. Treatment may include colic acid. Colic acid, marketed as Cholbam, is used for bile acid synthesis disorders caused by single enzyme defects. It may also be used as adjunctive treatment in selected peroxisomal disorders, including Zellweger spectrum disorders. The strategy behind colic acid is to replace a normal primary bile acid. This can improve bile flow and fat absorption. At the same time, feedback inhibition reduces the continued production of toxic bile acid intermediates. So the goal is not simply to help digest fat. More importantly, it suppresses the abnormal synthesis pathway. Example 3. Acute porphyrias. Acute porphyrias are masters of disguise. Acute intermittent porphyria, or AIP, and other acute hepatic porphyrias may cause abdominal pain, vomiting, constipation, a rapid heart rate, low sodium, and peripheral neuropathy during an attack. Patients may also develop anxiety, hallucinations, delirium, or psychosis-like symptoms. The presentation can look like psychiatry, gastroenterology, and neurology, all combined into one case. During an acute attack, the heme synthesis pathway in the liver becomes overactivated. Levels of delta-aminolevulinic acid, or ALA, and porphobilinogen, or PBG, rise. ALA, in particular, can injure the nervous system. The treatment strategy is to reduce ALA production. A mild attack may sometimes be treated with a high carbohydrate load to suppress the pathway. For severe or recurrent attacks, intravenous hemine may be needed. Hemine essentially tells the liver, "There is enough heme. Stop driving the pathway so aggressively." A more targeted RNAi therapy has also become available. It is called givosiran. Givosiran uses RNA interference to suppress aminolevulinate synthase 1, or ALAS1, in the liver. This reduces production of both ALA and PBG. Givosiran, marketed as Givlari, is used in adults with acute hepatic porphyria. Its purpose is to reduce the frequency of acute attacks. It is not simply a temporary pain medication used during an attack. This means that behind some psychiatric symptoms, toxic precursors from the heme pathway may be attacking the nervous system. Example 4. Carglumic acid. Carglumic acid is not an ordinary nitrogen-scavenging medication. It helps reactivate the first step of the urea cycle. The urea cycle requires an activating signal. That signal is called N-acetyl glutamate, or NAG. NAG activates carbamoyl phosphate synthetase 1, or CPS1. CPS1 is the key enzyme in the first step of the urea cycle. In N-acetyl glutamate synthase deficiency, or NAGS deficiency, the CPS1 enzyme itself may still be functional, but it is like a machine whose power switch has never been turned on. Without the activating signal, it cannot process ammonia effectively. Carglumic acid is a structural analog of NAG. It can replace the missing activating signal. It activates CPS1 and helps the urea cycle begin functioning again. Carglumic acid is used for acute and chronic hyperammonemia caused by NAGS deficiency. It is also used as adjunctive treatment for acute hyperammonemia associated with propionic acidemia or methylmalonic acidemia. Nitrogen scavengers give nitrogen an alternative route out. Carglumic acid turns the urea cycle's starting switch back on. Example 5. Primary hyperoxaluria type 1. Primary hyperoxaluria type 1, or PH1, is caused by a deficiency of the liver peroxisomal enzyme alanine glyoxylate aminotransferase, or AGT. Normally, AGT helps convert glyoxylate into glycine. When that pathway fails, glyoxylate is redirected toward the production of large amounts of oxalate. The human body cannot metabolize oxalate. It must be eliminated through the kidneys. The result can be recurrent kidney stones, nephrocalcinosis, chronic kidney disease, and in severe cases, systemic oxalosis. Traditional management has included high fluid intake, citrate, and pyridoxine in responsive patients. After kidney failure develops, combined liver-kidney transplantation may be considered. But PH1 now also has RNA-based treatment options. Lumasiran uses RNA interference to target HRO1 messenger RNA. This lowers the level of glycolate oxidase. That reduces the upstream supply of glyoxylate, and it lowers oxalate production at its source. Lumasiran, marketed as Oxlumo, is used in pediatric and adult patients with PH1 to lower urinary and plasma oxalate levels. Another therapy is Rifloza, also known as nedosiran. Nedosiran is a small interfering RNA, or siRNA, directed against LDHA. It is used in children 2 years of age and older, and in adults with PH1 who have relatively preserved kidney function. Its goal is to reduce urinary oxalate levels. These therapies are not traditional gene replacement, and they are not enzyme replacement therapies. Instead, they turn down an upstream pathway that produces a toxic substance. This reduces oxalate production. It shows how IEM treatment is moving beyond replacing what is missing. It can also silence an upstream enzyme that helps produce the toxic metabolite. Example 6. Cystinosis. Cystinosis is a lysosomal transport disorder. The problem is not that the patient eats too much cystine. The problem is that cysteine cannot be transported out of the lysosome. Over time, cysteine forms crystals. These crystals can damage the kidneys, the eyes, the muscles, the endocrine system, and the nervous system. The central treatment is cysteamine. Cysteamine enters the lysosome. There, it reacts with cysteine. This forms compounds that can leave the lysosome through other transport systems. The result is lower intracellular cysteine. When started early, cysteamine can significantly delay the progression of glomerular damage. Cysteamine eye drops can also reduce photophobia. If kidney function can no longer be maintained, kidney transplantation may become an option. This treatment can be understood as clearing a toxic substance from inside an organelle. It does not rely on dietary restriction, and it does not replace a missing enzyme. Instead, it creates a different chemical exit from the lysosome. Example 7. Menkes disease. Menkes disease is an ATP7A-related copper transport disorder. Copper cannot move normally from the intestines into the bloodstream. It also cannot be delivered effectively to the brain or to copper-dependent enzymes. Affected children may develop sparse, kinky hair, low body temperature, feeding difficulties, seizures, developmental regression, and abnormalities of blood vessels and connective tissue. In 2026, the U.S. Food and Drug Administration approved Zicubo, or copper histidinate, for pediatric patients with Menkes disease. This is a form of copper replacement therapy. Copper is delivered by subcutaneous injection. This bypasses the intestinal absorption defect and delivers copper directly into the body. This example teaches us something important. Some IEMs are not simply nutrient deficiencies. The real problem is a damaged nutrient transport system. Treatment must bypass the transport barrier that is no longer working. Example 8. Cerebral creatine deficiency syndromes. Cerebral creatine deficiency syndromes, or CDSS, include AGAT deficiency, GAMT deficiency, and SLC6A8, creatine transporter deficiency. Patients may develop speech and language delay, intellectual disability, seizures, movement disorders, autism-like features, or behavioral problems. Brain magnetic resonance spectroscopy, or MRS, may show a reduced creatine peak. In a GAT deficiency and GAMT deficiency, treatment focuses on creatine monohydrate. This helps restore the energy buffering system in the brain and the muscles. GAMT deficiency also requires lowering guanidinoacetate. Guanidinoacetate itself is neurotoxic. Treatment may therefore include ornithine supplementation and restriction of arginine or protein. Creatine used by athletes is not the same thing as therapeutic creatine replacement in an IEM. In an IEM, creatine is replacing a specific deficit in brain energy metabolism. Treatment must be guided by the diagnosis and careful monitoring. Example 9. Serine biosynthesis disorders. Serine biosynthesis disorders include conditions associated with PH-GDH, PS81, and PSPH. Patients may develop microcephaly, seizures, developmental delay, peripheral neuropathy, cataracts, or abnormalities of brain development. The body cannot produce enough L-serine. Serine is involved in protein synthesis, phospholipid synthesis, sphingolipid synthesis, one-carbon metabolism, and nervous system development. Treatment focuses on early supplementation with L-serine. Some patients may also receive glycine. For a healthy person, an amino acid may be just another nutrient. But for someone with an IEM, that amino acid may be a missing product. The purpose of treatment is not simply to improve general health. It is to fill a specific gap in the metabolic pathway. Example 10. Tetrahydrobiopterin deficiency. Tetrahydrobiopterin deficiency, or BH4 deficiency, is sometimes mistaken for a condition that simply resembles PKU. But BH4 deficiency is more complex than typical PKU. BH4 is a cofactor for phenylalanine hydroxylase. It is also a cofactor for tyrosine hydroxylase and tryptophan hydroxylase. Those last two enzymes are involved in the production of dopamine and serotonin. That is why treatment for BH4 deficiency cannot focus only on blood phenylalanine. Treatment often includes sapropterin to lower elevated phenylalanine. Depending on the specific form of BH4 deficiency, patients may also need neurotransmitter precursors. These may include levodopa with carbidopa, and 5-hydroxytryptophan, or 5-HTP. Some forms may also require folinic acid. Typical PKU and BH4 deficiency can both cause elevated phenylalanine, but their treatment strategies are not identical. Example 11. Niemann-Pick disease type C. Niemann-Pick disease type C, or NPC, is a neurodegenerative disorder caused by abnormal intracellular transport of cholesterol and glycosphingolipids. Patients may develop ataxia, vertical gaze abnormalities, difficulty swallowing, seizures, cognitive decline, psychiatric symptoms, and developmental regression. Miglustat has been used in certain countries and regions to treat NPC. It follows the strategy of reducing glycosphingolipid substrates. Progress in NPC treatment reminds us of something important. Some Neurodegenerative IEMs that once had only supportive treatment are beginning to gain medication options that target neurologic symptoms. Example 12. Alkaptonuria, or AKU, is an HGD-related metabolic disorder. Patients cannot properly break down homogentisic acid, or HGA. Over time, HGA accumulates in cartilage, the spine, the joints, the heart valves, and the urinary system. This can cause ochronosis, early-onset joint disease, kidney or urinary stones, and cardiovascular complications. Nitisinone inhibits 4-hydroxyphenyl pyruvate dioxygenase at an earlier step in the pathway. This reduces the production of HGA. It can substantially lower 24-hour urinary HGA levels. The same medication can act as an upstream brake in different IEMs. In HT1, nitisinone reduces toxic downstream metabolites, such as succinylacetone. In AKU, it reduces production of homogentisic acid. The diseases are different, the pathways are different, and the monitoring goals are different. Example 13. X-linked hypophosphatemia burosumab, marketed as Crysvita, is used to treat X-linked hypophosphatemia, or XLH. It does not simply replace phosphate. It blocks fibroblast growth factor 23, or FGF23. This improves the kidney's ability to reabsorb phosphate. It also improves vitamin D metabolism. The common principle behind these therapies is not simply replacing nutrients. It is precisely changing a specific metabolic pathway. CTX is treated with chenodeoxycholic acid to suppress abnormal bile acid-related metabolites. PH1 can be treated with RNAi to reduce oxalate production. Carglumic acid reactivates the first step of the urea cycle. Cysteamine helps cysteine leave the lysosome. Givosiran reduces porphyrin precursors. Folinic acid, also known as leucovorin, is used for FOLR1-related cerebral folate deficiency. And Kebilidi delivers the AADC gene to targeted regions inside the brain. Together, these treatments show that IEM therapy is no longer limited to general metabolic support. It is moving toward true pathway-level intervention. Chapter 14, a trap that must be avoided. Unproven stem cell neural repair. Many people with IEMs have developmental delay, seizures, abnormal muscle tone, autism-like features, behavioral or psychiatric symptoms, or lasting effects of brain injury. Some clinics market unproven treatments using phrases such as brain cell repair, neural regeneration, or claims that stem cells can cure autism, cerebral palsy, or psychiatric illness. This is an area where families must be cautious. Stem cell-based treatments that have been rigorously shown to be effective and authorized by regulators remain limited to selected clinical settings. Many so-called neural repair stem cell treatments have not gone through rigorous multi-phase clinical trials. Their safety and effectiveness have not been established. These treatments may not only fail to help, they may cause physical harm, psychological harm, and devastating financial harm. For someone with an IEM, the order of treatment is especially important. If the underlying metabolic disorder is not controlled, toxic metabolites will continue accumulating. Energy failure may continue. Metals may continue to build up, and hyperammonemic crises may continue damaging the brain. Even if true neural repair technology becomes available in the future, the underlying metabolic problem would still need to be controlled first. Looking advanced does not prove that a treatment works, and a high price does not mean the evidence is stronger. Chapter 15. What really needs to be monitored, not just the symptoms. IEM treatment cannot rely only on questions such as, does the patient seem better today? Did they have an episode today? Do they appear to be making progress? Symptoms matter, but biochemical markers are like fingerprints left behind at the scene. In PKU, monitoring may include blood phenylalanine, tyrosine, the phenylalanine to tyrosine ratio, growth, and nutritional status. In MSUD, monitoring includes leucine, isoleucine, and valine. Leucine is especially important. In a UCD, monitoring may include blood ammonia, glutamine, urinary orotic acid, the plasma amino acid profile, and neurologic status. In organic acidemias, monitoring may include urine organic acids, the acylcarnitine profile, acid-base status, blood ammonia, lactate, and ketones. In fatty acid oxidation disorders, or FAODs, monitoring may include the risk of hypoglycemia, the acylcarnitine profile, creatine kinase, or CK liver function, cardiac involvement, and tolerance of fasting. In glycogen storage diseases, or GSDs, monitoring may include blood glucose, lactate, uric acid, triglycerides, liver and kidney status, and overnight hypoglycemia. In Wilson disease, monitoring includes copper-related laboratory markers, liver function, neurologic and psychiatric findings, and medication side effects. In CTX, monitoring may include cholesterol, bile acid precursors, neurologic progression, eye findings, and tendon involvement. In porphyria, monitoring may include ALA, PBG, sodium and other electrolytes, liver function, and potential triggers. In PH1, monitoring may include urinary oxalate, plasma oxalate, kidney function, nephrocalcinosis, and kidney stones. In cystinosis, monitoring may include white blood cell cysteine, renal tubular function, corneal crystals, growth, and development. For disorders involving folate, vitamin B12, and 1-carbon metabolism, monitoring may include homocysteine, methionine, methylmalonic acid, vitamin B12, folate, and when necessary, cerebrospinal fluid 5, MTHF. In mitochondrial disease, monitoring may include lactate, pyruvate, the acylcarnitine profile, CK, liver and kidney function, an electrocardiogram or ECG, an echocardiogram, eye examinations, hearing tests, brain MRI or MRS, and the patient's genetic findings. When treatment is working, the first sign is not always that a child suddenly becomes normal. The first changes may be biochemical. The laboratory markers improve. Metabolic crises become less frequent. Development becomes more stable. Seizures decrease, and behavior or cognition may stop getting worse. If we look only at the surface, we can easily misjudge what is really happening. Final thoughts. Treating an IEM is like solving a case you cannot stop. After finding one suspect, the treatment of an inborn error of metabolism cannot be reduced to one medication, one diet, or one operation. Some disorders require substrate reduction. Some require replacement of a missing product. Some are especially vulnerable to fasting and infection. Some can use cofactors to improve residual enzyme activity. Some require nitrogen scavenging medications or chelating agents to remove toxic substances. And some use enzyme replacement therapy to reduce the burden on affected organs. Certain disorders need highly specific treatments. These may include chenodeoxycholic acid, cholic acid, hemin carglumic acid, lumasiran, cystimine, copper histidinate, creatine, L-serine, B4 related therapy, migalastat arimoclomol, levacetileucine, or nitisinone. Some liver-based metabolic disorders may be treated with liver transplantation. Some mitochondrial disorders require individualized management using coenzymes, antioxidants, diet, and exercise. A small number of disorders now have gene therapies. Many more are still waiting for treatments that are safe, effective, accessible, and directed at the underlying cause. One of the most dangerous things about an IEM is its ability to hide. It can look like gastroenteritis, like epilepsy, like developmental delay, like a psychiatric disorder, like liver disease, a muscle disorder, picky eating, or a behavioral problem. But many injuries may be preventable when the disorder is recognized early. Many metabolic crises may be avoided, and when children enter the correct treatment pathway in time, they may be able to avoid repeated irreversible metabolic injuries. The real key is to bring the symptoms back to the biochemical scene of the crime. Find the blocked metabolic pathway. Find the substrate that is accumulating. Find the product that is missing. Find the toxic metabolite that is out of control. Find the residual enzyme activity that still remains. And find the part of the pathway that treatment may still be able to rescue. One final reminder. Do not begin high-dose folic acid, 5-MTHF, folinic acid, hydroxycobalamin, B-complex vitamins, or a mitochondrial cocktail simply because someone has psychiatric symptoms, developmental delay, seizures, or autism-like features. The right approach is to bring the medical history, physical findings, and laboratory clues to a physician. When necessary, the patient may need a coordinated evaluation by neurology, metabolic genetics, a metabolic dietitian, and an experienced psychiatry team. When a treatable metabolic cause truly exists behind psychiatric symptoms, thinking of it earlier can lead to earlier screening, and earlier screening may lead to treatment that targets the real cause sooner.